In the next 5 lectures, we will be going over the neurologic examination. And the emphasis here is not really on the how to perform the examination, although there will be some discussion about that. The purpose here is really to explain how the neurologic examination allows you as the physician to assess the brain and various pathways, all of the neuroanatomy that we're talking about. This is how we get the neuroanatomy to talk to us and to evaluate anything from the brain all the way down to the big toe. So for example, you take out your safety pin and you tap the big toe and the patient says, yes, that feels sharp. Well, you assess information about peripheral nerves all the way down in the foot, all the way up to the sensory cortex in the brain and through the spinal cord, and it provides very valuable information. So we will go over the neurologic examination looking at 8 major components. We'll spend the least amount of time talking about these first 2 here, mental status, language and speech. We'll spend quite a long time on cranial nerves, then the motor exam, reflex exam, sensation, cerebellar testing, and gait. Okay, and I will just say that of the all of these different components here, don't forget to have your patient walk, because just being able to walk tests so much of all of these other components as well. So in terms of prioritizing things, I would say the history is almost always the most important aspect of our neurologic evaluation of a patient. The exam is very useful, but I know I'm in trouble if I've spent 30-40 minutes talking with the patient. I have no idea what's going on, and usually in that situation the exam does not then open everything up. The exam helps to narrow down and refine what you're thinking is going on based on the history. Neuroimaging, and there is a trend now because MRIs are incredible, very detailed. Just to think, well, let's just get an MRI scan of the brain and figure out what's going on. But no, the neuroimaging is to confirm what we already suspect is going on based on our history and on our examination. And I'll just give one example of that. Here is a CT of a patient who has something obvious going on here. And there was a patient that I saw a number of years ago who came into the hospital with sudden onset left-sided weakness. And a CT was obtained, and this was found, and the patient was rushed off to have surgery. This was removed, and the patient's left-sided weakness did not improve at all, and then neurology was consulted. So what's the problem with this? Well, we have an overwhelming finding here that's really obvious, so we're impressed with the neuroimaging, but what are we looking at here? Remember, whenever you look at a CT or MRI scan, you need to imagine the patient is on their back with their feet coming out toward you. Okay, that means this is the left side. So we have something going on here on the left side of the brain. Well, I think you know enough about neuroanatomy already to know that it is the right side of the brain that moves the left side of the body. So this lesion, impressive though it is, does not explain left-sided weakness. And also this just has the appearance, it's very well defined. This looks like something that's been there for a long time. So it turned out that this was a meningioma, which is a benign brain tumor, that probably the patient had this for many decades. It was causing no symptoms. And a CT, which this is a CT scan, is pretty insensitive for detecting an acute stroke. So it's not surprising actually in the first few hours that we don't see anything over here. If we were to re-image the patient a day later or do an MRI scan, we would certainly find the stroke. So this was an example of prioritizing neuroimaging and an obvious lesion here, but it made no sense based on the history, made no sense based on our examination of the patient. So again, this is confirming, and there are cases where we're not sure what's going on based on the history and the exam, and we're surprised to find something on neuroimaging. But this is generally, in the priority of things, it's like this. History trumps exam, which trumps neuroimaging. So when we're thinking about neurologic patients, our first priority is to localize the lesion. And you will hear neurologists talk about this a lot. We love to talk about where is the lesion, because this is not an academic, theoretical exercise. This is very practical. Okay, so this is our neuroaxis. We start with the cortex of the brain, and then down to subcortical structures, brainstem, cerebellum, spinal cord, anterior horn cell, nerve roots, plexus, peripheral nerve, neuromuscular junction, and muscle. That is our neuroaxis. So when we talk about localizing the lesion, we want to put the lesion into one of these anatomical subcategories. So for example, a patient comes into the emergency room with weakness. Well, weakness can be a problem with the upper motor neuron pathways and cortical and subcortical structures. Weakness can be due to a brainstem lesion affecting upper motor neuron pathways. Weakness can be due to spinal cord compression. Weakness can be due to anterior horn cell disease, root disease, plexus, peripheral nerve, neuromuscular junction, or muscle. So our differential anatomically for a patient who's weak goes all the way from the brain all the way down to the muscle. So when we ask the question, where is the lesion? The reason it's practical is, well, is the patient weak because of a lesion in the brain or brainstem? Well, then we better get an MRI of the brain. Is the patient weak because of cord compression? Then we better get an imaging done of the spine. Is the patient weak because of some peripheral root, plexus, peripheral nerve problem? Well, there we might want to do a test called an EMG to help us figure out what's going on. Is it neuromuscular junction or muscle? There we're going to do some different testing. We might need to do a muscle biopsy or some special antibody testing. So localizing the lesion is always the first step, because if we can localize it down and say, I think the problem has to be spinal cord, well then we're going to know what testing we need to do to figure out what it is that's compressing the spinal cord, for example. So localize first, and then we try to figure out what is the cause, what is the etiology. So just as a kind of a general guideline to etiology, things that come on acutely, like the patient was normal and all of a sudden they have a dramatic problem. They can't move one side of the body, for example. That is usually due to vascular disease, like a stroke or a hemorrhage. Okay. Things that come on more slowly, so now let's say the right-sided weakness came on over months and months. That sounds more like a mass lesion, like a tumor, or even an abscess, or several different things can present as a mass lesion. Some things in neurology tend to come and go. Patient's normal, then they have a problem, it goes away, then it comes back again. So multiple sclerosis would be a classic example of that, but we'll also see that with a lot of the benign headache syndromes like migraine headaches. Neurodegenerative conditions like Alzheimer's or Parkinson's just tend to gradually progress. Every few months is worse than the last few months. I'll say a few things about the neurologic history. Even though I said that is usually the most important thing, most of these 5 hours will be spent on the other aspects of the examination. But I just need to make a little plug here for the importance of taking a very accurate, detailed description. And so what we want in neurology when you're on the clerkship, someone comes in with dizziness, we want to know when it started. We want to know what it's like, some details. And as I mentioned, this is the single most important contributor to making the correct diagnosis. So here is more or less a transcript of an encounter I had with a patient some time ago, just to kind of illustrate this. So the patient said, I've been feeling dizzy recently. And I said, well, tell me what happens. And the patient said, well, I get dizzy once in a while, that's all. It's hard to explain. Wonder doctor told me it was probably a virus. I saw Dr. X who ordered a brain scan, and then he sent me to an ear, nose, and throat doctor who did other studies and thought that. And I did let the patient carry on for longer than this, but you know, he wanted to talk about the doctors he'd seen, the testing that was done. But what I really want to know is a detailed description. You know, what do you mean by dizzy, right? So I said, well, tell me about the first time you noticed the dizziness. And he said, oh, it's been going on for quite a while. I figured it was probably the flu at first. Okay, don't give up. We still don't know much at all about this patient, but we need to keep probing for what the patient is really trying to communicate to us. So I said, well, tell me about the first time, trying to be really specific. And the patient said, I was at home and I just felt dizzy. I wish I could describe it better. And so I asked, well, what were you doing at the time? And the patient says, I was just rolling over in bed. Okay, that actually, when you know more about dizziness, that actually is an important clue. And so now I ask the patient, well, use another word besides dizzy to describe what you felt at that moment. And he said, well, I felt like I was on a boat and the whole room seemed to be moving around. I also felt nauseated and I threw up. It was awful. That's about it. Then I went to see my doctor to try and then again, we're kind of off on a tangent here. But now we're actually getting somewhere, because dizziness can mean the lightheaded feeling we've all had when you stand up too quickly. Dizziness can mean vertigo, where there's a sensation of movement. And that seems to be what this patient is describing. On a boat, the whole room seemed to be moving around. So this actually is very helpful. I am now in a vertigo category. We're narrowing down the differential based on the patient's description. So again, I interjected, well, first tell me what happened next at home that day. And the patient said that seasick feeling lasted about 10 seconds. Now that's very specific, very helpful. And I thought I was going to die. Then it was over and I felt okay until it happened later that afternoon. So I asked, have you noticed that rolling over in bed often brings on these spells? Patient, yeah, and it's funny that you ask, but it seems to often happen when I roll over or turn my head to the right. That will bring it on almost every time. Not that that means anything. And of course that means everything. We are dealing here with a condition just based on the history that we will talk about in a lot of detail later, called benign paroxysmal positional vertigo, where patients, usually lying down or rolling over in bed, have brief episodes of vertigo that generally last for seconds. It's horrible. They feel like they're going to throw up. And so the history here is the only way, really, we're going to make this diagnosis. All of the neuroimaging testing in the world is normal in this condition. Okay, we diagnose it by the history, and then there is something specific that we can look for on examination to help confirm the diagnosis. Okay, but if we just say, okay, we've got a dizzy patient, let's just do an MRI scan of the brain and get our answer, that's not how it works. All right, so let's start with a little bit about the mental status examination. And when we get to dementia later on in the course, I'll have more to say about this. So we want to ask the patient orientation questions, which would be, do you know your name? Do you know where you're at? Do you know why you're here? These would be kind of general orientation questions. Then we'll do some memory testing. So we'll ask the patient to immediately recall some objects. I like to give patients 4 objects: Mr. Johnson, tunnel, red car, and Boston. I would suggest you use the same 4 because you'll get confused yourself and forget if you're changing them every time. And so I'll ask the patient to immediately repeat those back to me. And then we may need to practice that a couple of times. And then I will tell the patient, I'm going to ask you again in about 5 minutes to repeat those 4 objects. So try to keep them in your mind. Okay, so we're testing more remote memory with that. Attention testing would be to give the patient 7 numbers and then ask them to repeat those 7 numbers back to you. We'll do some math testing as well, and later on we'll talk about the areas of the brain involved in that. We'll check construction. I like to have the patient draw either a cube or draw a clock with the big hand and the little hand, and the time is 11:20. Okay. When you rotate with neurology, you will sometimes see us ask patients rather unusual questions. We might ask them to interpret a proverb. I work with a neurologist who likes to ask patients, do helicopters eat their young? And, a quotes normal patient would laugh at that. But if we have someone with something like Alzheimer's dementia, they may appear superficially normal. They're telling you jokes, they're outgoing, and you ask them a question like that and they might say, well, I suppose under certain circumstances they might. And then you realize, okay, there really is a problem going on here. We like to ask general information. So if they watch TV, as older individuals frequently watch the news all the time, what's going on in the world? Who's the president? Some basic things like that. I like to ask patients if they can define what an island is and then list as many islands as they can. So we put all of this together to get information about the cognitive function of the patient. Here is a MoCA test, which is one of the more standard ones that is used. You can look through that. I'm not going to ask you detailed questions about this, but it is helpful. We fill this out on a patient and we put the date on it, and then when they come back 4 months, 6 months later, we can repeat the testing to see if their cognitive function is changing. Now, a quick thing that you can do in the hospital, or if a patient, let's say they're intubated and they can't communicate, or maybe they have an aphasia and they can't speak, and we want to know how much are they understanding, we can ask a patient to follow 3-step commands. So a 3-step command is touch both shoulders 2 times with 2 fingers. Okay, so that's a 3-step command, and if a patient can follow a 3-step command, that says good things about their overall cognitive function. It's a quick, kind of sometimes an emergency room, quick evaluation of someone's mental status. A very easy 1-step command would be to close your eyes or maybe open your mouth. A 2-step command would be close your eyes and point to the ceiling. Now, regarding just being awake and conscious, you need 2 structures, 2 central nervous system structures to be awake and conscious. You need to have an area down in the brainstem that I'll show you pictures of later called the reticular activating system, which you can kind of think of as the light switch down in the brainstem that activates the brain, which is the light bulb. So if you knock out too much of the reticular activating system in the brainstem, your patient will be confused at best or completely unresponsive. Okay? And you need to have just one cerebral hemisphere to maintain consciousness. So we see patients, for example, that have a massive stroke on one side of the brain that come in awake, talking. Okay? But when we have involvement of both hemispheres, that then would be enough to result in a patient who is unresponsive. So with regards to mental status, these are 2 of the more common conditions that would affect mental status. One is dementia. It's now called a major neurocognitive disorder, but we'll still use the older term dementia. And Alzheimer's makes up more than 70% of all patients that come in with dementia. And these dementia syndromes, like Alzheimer's, do not just involve memory. The whole brain is affected. So although it usually does start with memory loss. And so there's a gradual deterioration, not just in memory, but even in motor function, the ability to do basic things like brush your teeth and dress are affected as the disease progresses. Encephalopathy, or delirium, neurologists like the term encephalopathy. I think psychiatry prefers delirium. But this is generally something that comes on rather acutely. This is something we see in patients who are in the hospital who are confused. And there is an infinitely long list of things that can cause encephalopathy. If someone has an infection or a metabolic disturbance, like their electrolytes are out of whack, or their glucose is too high or too low, or they're intoxicated with alcohol or other drugs. These are all some of the things that can cause encephalopathy. And so you should be able to distinguish. We might see someone in the emergency room. There's no family there. We don't know when did this start. And you're just interacting with a patient who's confused. How do you know if it's dementia or encephalopathy? So here are some of the distinguishing factors. And encephalopathy tends to come on acutely. The patient was normal until yesterday That's not dementia. Dementia comes on very slowly. It's very chronic. So dementia, chronic progressive decline, whereas an encephalopathy will often fluctuate. You know, the patient was awake and doing well, now they're very confused, and they became more awake, and now they're confused again. That kind of fluctuating course points towards encephalopathy. Okay, but the next one here is, I would think, probably the most helpful. If you see someone, even with a more advanced dementia, their attention is pretty good. In other words, they're alert, they're looking at you, they're answering questions. They might be wrong, you know, they might be telling stories that don't relate to what you just asked them, but their attention is pretty good. An encephalopathic patient, though, these are patients you need to tap on the shoulder and continue to alert them because they keep falling asleep. You know, Mr. Jones, wake up. And then Mr. Jones wakes up, he answers a few questions, and then he falls asleep again. So that's attention is profoundly involved in an encephalopathy. And in encephalopathy, these are generally reversible. You know, the alcohol wears off. The electrolytes return to normal. You treat the infection, and the patient's back to normal. Dementia syndromes are rarely reversible. Now let's talk a little bit about language and speech. Slurred speech is known as dysarthria. Okay, and this affects the vocal apparatus, and so this can be to neurologic and non-neurologic abnormalities. For example, if a patient has encephalopathy, well, just think of someone who's very intoxicated with alcohol, their speech is going to be slurred. And so most patients with encephalopathy have dysarthria that will go along with their confusion. If someone has an abnormality with the vocal apparatus or a problem with their dentures, that's going to affect their speech and give them dysarthria. Okay, but what we'll spend much more time talking about in this course is aphasia. And these are the areas of the brain responsible for understanding speech and then being able to output speech normally, like in conversation. So for most individuals, even if you're left-handed, the left hemisphere is language dominant. Now, if someone's right-handed, they're almost certainly, like more than 95%, language dominant in the left hemisphere. If you're left-handed, yeah, 30% you could be language dominant in the right hemisphere. And so whenever someone comes in with a stroke, with language problem, we always ask them, are you right or left-handed? Because that information more strongly suggests that they could be language dominant in the left hemisphere. So there are several ways to test language function. This can be done quickly. We'll have a patient repeat sentences. So please say, today is a sunny day. Please say, no ifs, ands, or buts. And that's a very good screening test to assess the language areas of the brain. We'll have a patient name objects. I like to point to my knuckles or maybe the band on my watch and ask a patient what part of the watch is that. We can have a patient read. We can have the patient write. Okay? All of these assess the language areas of the brain. So we've already shown you Broca's area on the left hemisphere. So remember, this is on the posterior portion of the inferior frontal lobe. Okay, and so left hemisphere. And so if we were to have an isolated lesion there in the expressive language area, then these patients will just have a poverty of speech output. They understand because Wernicke's area is intact. They just can't get the words out very well. It's very effortful. Okay, so these are patients we may want to ask them to follow three-step commands, because if Wernicke's area is intact, they understand everything, okay, but just can't get the words out. Also, the normal melody of speech is affected with the Broca's aphasia. It's really amazing how we're able to speak and how it's timed perfectly with breathing and just imagine singing, how all of that is coordinated so perfectly. Everything is very clumsy, awkward with regards to speech output in someone with a Broca's aphasia. In class, I will show you an example of that. Now, Broca's area is immediately adjacent to the precentral gyrus, which is the motor cortex for the face and arm. So usually, patients with a Broca's aphasia will have weakness on the opposite side of the body, especially involving the opposite face and arm. Okay, those two things tend to go together. Okay, so here's Broca's area, and just notice that the precentral gyrus is very close to that. Okay, and so remember, both of these are supplied by the middle cerebral artery, so it often is a middle cerebral artery stroke that will affect Broca's and the precentral gyrus. Okay, so in terms of Wernicke's area, the most important part of Wernicke's area by far is this portion here, this more posterior portion of the superior temporal gyrus. You know, yes, there is some function of the supramarginal and angular gyrus, but predominantly when we think of a Wernicke's aphasia, you want to be thinking about the temporal lobe. That's the most important. So this is the part of the brain where we understand. Okay, so if you understand this lecture so far, then Wernicke's area is working well. Okay, so, but if we do have an isolated lesion there, now we have someone with fluent speech because Broca's area is intact, right? Lots of words are coming out. But if you engage in conversation with these patients, what you say to them correlates very little with what they say back to you because they're getting lots of words out, but they don't understand what you're talking about. And so again, the video I will show in class I think will be helpful for this. Listen carefully to patients with an aphasia. Patients with Wernicke's aphasia usually make multiple paraphasic errors. What that means is a word, it can be a word that doesn't exist, like the grass is greel, or it can be a word that exists, but it's used in the wrong context. The grass is blue. And there are names for the different types of paraphasic errors that I don't care that you know, but listen to those carefully because it's a classic feature of a receptive aphasia. So when you hear someone with an aphasia, I would say the first question you want to ask yourself, are they fluent or not? Okay? If they're fluent, the lesion is more posterior towards Wernicke's area. If they're non-fluent, the lesion is more anterior towards Broca's area. Now, we can have a global aphasia. So remember, the middle cerebral artery supplies all of this. So if we have a big left middle cerebral artery stroke, now we have a patient who can't understand, and we have a patient who can't speak. So that's called a global aphasia, the worst type of aphasia we see. A conduction aphasia is rare, but yet a common board question, I'm told. And that involves the pathway that connects Wernicke's and Broca's area, and that is called the Arcuate fasciculus pathway. Okay. Now, just think about why this is needed. You're in conversation with someone, and someone asks you a question. You understand the question here in Wernicke's area. Now you want to respond. Well, you need to move that program, what you understood here in Wernicke's area, to Broca's area to respond. So you need the Arcuate fasciculus in conversation. So if we have an isolated lesion here of this pathway, the Arcuate fasciculus, then these patients usually come in with kind of a vague language problem, and we do all the language testing, and what really stands out is that these patients cannot repeat sentences. Okay, that deficit stands out more than any other. Okay, why is that? Well, let's say we ask a patient, can you say no ifs, ands, or buts? They understand. Okay, doctor wants me to say no ifs, ands, or buts, but they have no way of getting that information to Wernicke's area to actually repeat the sentence. So an isolated, severe problem with repeating sentences suggests we have a lesion in the Arcuate fasciculus. Now, there are other less common types of aphasia that are called transcortical motor and sensory aphasia. And so both of these tend to occur in what is known as a watershed stroke, which is where the whole brain just doesn't get enough blood flow. Maybe someone had a cardiac arrest and they have CPR, and for that period of time there just wasn't much oxygen or pressure going to the brain. And so there are these watershed areas in the brain. Here is one between the anterior and middle cerebral artery territory. Here's another between the middle cerebral artery and the posterior cerebral artery. And so a transcortical motor stroke looks a lot like a Broca's aphasia. Again, the lesion is more anterior, so it's a non-fluent aphasia, but the connection between Wernicke's and Broca's, the Arcuate fasciculus, is intact. So unlike a patient with a pure Broca's aphasia, patients with a transcortical motor aphasia, they can repeat sentences pretty well because the kind of the hard wiring between Wernicke's and Broca's area is intact. Likewise, a transcortical sensory aphasia, where the lesion is back here, looks a lot like a Wernicke's aphasia. They're fluent, lots of words are coming out, but they don't understand very well. Okay, but because the connection between Wernicke's and Broca's area, the Arcuate fasciculus, is intact, these patients can repeat sentences pretty well. Okay, and you might ask, okay, well, if someone can't understand, then how could they repeat a sentence? And that's a very good question. So usually what happens when we're in conversation with these patients, they may just echo back things that you just said to them. Okay, so you ask them, what's your name? And maybe they say, what's your name? Back to you. Okay, they didn't really process that. They kind of echoed that back to you. But that would indicate that the Arcuate fasciculus here and the ability to repeat a sentence is intact. Admittedly, I haven't seen that very often, but at least in theory, that's what a sensory aphasia would look like. Okay, so here is a summary of the different aphasias that we've talked about. So in a global aphasia, everything is knocked out. They're non-fluent, they don't understand, they can't repeat sentences. That's usually a big middle cerebral artery stroke. Okay, if we have an isolated Broca's aphasia, they're non-fluent, but Wernicke's area is intact, so they understand. Okay, but they can't repeat sentences because to repeat a sentence, you need to be able to get the words out, right, in Broca's area. So the lesion here is of the inferior frontal gyrus. Remember, a transcortical motor aphasia looks just like a Broca's. They're non-fluent. Okay, they can't understand because Wernicke's area is intact, but because the Arcuate fasciculus is not involved, they can repeat sentences fairly well. Well, they're going to struggle, but they'll be able to get them out better than someone with just an isolated lesion of Broca's area. Wernicke's aphasia, so they're very fluent, lots of words coming out, but they don't understand, and they can't repeat sentences. Remember, transcortical sensory looks just like a Wernicke's, but they can repeat sentences pretty well. And a transcortical mixed, it means it's a larger watershed stroke that is both transcortical motor and sensory. So these patients look like a Broca's, they look like a Wernicke's, but yet they may echo back some sentences. Okay? And remember, if we have an isolated lesion of the Arcuate fasciculus, these patients are pretty fluent, they understand pretty well. Their main deficit they have is they can't repeat sentences. All right, let's spend a little bit of time now talking about cranial nerves. We'll say the least about the olfactory nerve. Okay, so we've seen in lab the olfactory bulb and tract, and the actual olfactory nerve are these little nerve fibers here that pass through the cribriform plate. Okay, and so we can just, here's the olfactory bulb and olfactory tract. And so usually loss of smell is not neurologic. Someone has a cold, they're a smoker. There are lots of non-neurologic reasons to have loss of smell. In the neurologic realm, we see this often after patients that have had head trauma. There's a tumor called a meningioma that will often grow right in the olfactory groove. And so these patients have loss of smell and usually headaches as well. And Parkinson's disease, like 90% of patients with Parkinson's have loss of smell, as sometimes even predates the tremor or the other features of Parkinson's. So in these situations, we do have these scratch and sniff cards in our office where we can have the patient occlude one nostril. We'll check sense of smell in one nostril and then compare that to the other side. Okay, so again, in head trauma, what happens is the impact just shears the olfactory nerve fibers here. Okay, so again, really common. And of course, non-neurologic, I should mention COVID, since that was a common feature, early feature of COVID infection. Here we have a mass lesion at the base of the brain. So this is that meningioma here that would cause headaches because of the mass effect on the brain, and also involve the olfactory bulb and tract, and will cause a loss of smell. Now, one thing is that smelling salts, you've seen like boxers, they use that. This does not assess the olfactory nerve. Okay, this ammonia gas that's released actually irritates the trigeminal nerve, pain fibers. Okay, so it is not an assessment of olfaction. Okay. Now, one other thing, and I guess it's partly because it's funny, it's also sad at the same time, but usually in our neurologic examination, we check cranial nerves 2 through 12. We do not check the first cranial nerve unless there's an indication, the patient's complaining of loss of smell, or maybe we're doing a Parkinson's evaluation. But if you think this patient you're evaluating that it may be a legal case and you're wanting to do a complete neurologic examination, check for olfaction. And the reason is, it is a lawyerly trick to ask a neurologist or a physician on the stand, did you do a complete neurologic examination? And you proudly look over your note, and yes, I did a complete examination. Well, doctor, did you check the first cranial nerve? And you explain, well, no, but it's not relevant. And the lawyer will interrupt and say, so you did not check the number 1 cranial nerve, and try to impress the jury, with the theatrics. Okay, so if it's a legal case, check sense of smell, and then you can say in court that you checked the number 1 nerve. Now, moving back to the optic nerve, which we can see right here, the optic nerve and chiasm. Okay, we'll talk about 4 ways to evaluate the optic nerve and visual pathways that go all the way back to the occipital lobe from the optic nerve. So we can assess visual acuity, visual fields, the ophthalmoscopic examination, and the pupillary light reflex. So visual acuity, you've all seen the Snellen eye chart on the wall, and when you're on inpatient service, you will carry a little pocket version of this. And you can hold this at a certain distance away from the patient and assess visual acuity. Now, in neurology, we're not assessing the patient for glasses or refractive errors. We want corrected vision. We want the patient, to have their glasses on when we check visual acuity. Okay, so obviously this is important, especially if the patient is complaining of visual loss, that we can objectify by doing visual acuity testing. Visual acuity assesses central or macular vision. And so the macular fibers, actually half of the macula in each eye crosses over right at the optic chiasm. And it turns out that if you assess visual acuity in someone who has lost half of their macular vision, let's say they have a lesion in the left hemisphere that has affected half of the macular fibers that crossed over, well, visual acuity is 20/20 with half of a macula. So what that means is that, in general, only lesions that are anterior to the optic chiasm have any effect on visual acuity. Okay? In theory, if you had bilateral lesions in both hemispheres, then you could knock out enough of the macular fibers to affect visual acuity. But practically, when someone has a loss of visual acuity, the lesion is anterior to the optic chiasm. So for a neurologist, that's optic nerve. Okay, for an ophthalmologist, maybe it's something in the eyeball, it's the lens, or they have a cataract, or they have something in the vitreous. Okay, but it's a more anterior lesion that will cause a loss of visual acuity. Okay, so when we think of vision here, we will talk about the retina in terms of a nasal retina that we can see here, and a temporal or an outer retina. Okay, And we think of what the patient looks at as either, in this case, let's say this is the left eye, this is the right eye, this is what the patient sees. So out here would be the temporal visual fields, and these would be the nasal visual fields. Okay? And so I would come back and look at this just to notice what each part, like this temporal upper portion of the retina, notice what does it see? It sees the nasal visual field right here, whereas the lower temporal retina sees the upper nasal visual field. Okay, and so we can follow vision here from the nasal and temporal retina, and we want to know what vision stays on the same side, what vision crosses over. So notice that the nasal retina, whatever is the nasal retina, those are the fibers that cross over at the optic chiasm. Okay, what does the nasal retina see? Well, the nasal retina sees the temporal, or the outer visual field. And so you'll just have to spend some time looking at this, because you do need to understand where lesions of the optic nerve, or of the chiasm, or of the optic tract, what type of visual loss the patient will have. One other thing I would just suggest maybe to label on this diagram is right here at the center of the optic chiasm, you see this little X here. These are the macular fibers. So half of a macula crosses over, half of the macular vision stays on the same side. So these are the crossing macular fibers. So a condition that involves the optic nerve is called optic neuritis. And here we can see inflammation of the optic nerve on this side compared to this side. So this is something that commonly occurs in a condition called multiple sclerosis. Multiple sclerosis, we have a whole hour lecture on multiple sclerosis, but the big picture is these patients have episodes of central nervous system demyelination. And the optic nerve is part of the central nervous system. Okay, cranial nerves 3 through 12 are all part of the peripheral nervous system. How do we make that distinction? Well, the optic nerve is myelinated by oligodendrocytes. Oligodendrocytes myelinate the brain, the spinal cord, and the optic nerve. They're all part of the central nervous system. Cranial nerves 3 through 12 and all of your peripheral nerves from the roots all the way down are myelinated by Schwann cells. They're all part of the peripheral nervous system. Okay, so one of the most common presentations of multiple sclerosis is optic neuritis, and these patients come in with rather sudden loss of vision. There tends to be a lot of swelling here, and so patients will have pain behind the eye. They will say even looking around is painful behind the eye. It tends to be, when someone has an optic nerve lesion, they tend to lose central vision. This is called the central scotoma, okay, which is kind of classic for optic neuritis. You can imagine this patient trying to look at a Snellen eye chart. Their visual acuity is going to be very poor, because reading or identifying letters on a Snellen eye chart requires central vision. So they have very poor visual acuity. All right, the next assessment here of the optic nerve is visual field testing, and I think we'll spend a good chunk of time on this, so I think we'll stop here and pick up in the next lecture.